All right, everyone, we're going to get started. Thank you all for coming today. I really appreciate it. I know we have people from, where are you guys from, your group, your club? University of Oregon, which is really cool. We didn't even mark it there, so that's really awesome that you guys found us. Thank you guys for coming. My name is Marissa Sofsky. I'm a 5 of 5 ND student at the National University of Natural Medicine. I'm the president of SAME until about 8 o'clock this evening. It's been an amazing 2-year run, but I'm passing off leadership soon. So I really, really appreciate you guys coming. We have an amazing event for you guys today. Just to give a little background around who we are as an organization, for those of you who don't know, we are the Student Alliance for Integrative Medicine. We're right now made up of schools here in the Portland area, a naturopathic school, chiropractic school, Chinese medicine, chiropractic, sorry I said that, Pacific University, which has a bunch of different programs, and then OHSU, which is the conventional medical school. So it's a really awesome organization that brings together students from all these different professions to work together, to collaborate, to create the future of healthcare that we want to see. So if you have any questions about the organization, please come find me, find anyone who's wearing one of these blue little name badges. We're all representatives of the organization. Without further ado, I want to pass on to the first panel, and we have Christine introducing.
Hi, everyone. Give me just one moment to figure out the mic. All right. Okay. Is this working? Can you hear me from here? Perfect. Hi, everyone. My name is Christine McClure. I'm a 4 out of 5 ND student at NUNM, and I'm currently the president-elect of the Student Alliance for Integrative Medicine until about 8 o'clock tonight. So then I'll be taking over leadership. And this morning, we're starting with our first panel. I just want to go over a couple of housekeeping things before we get started. The name of this panel is, I'm going to look because it's a long title, Addressing the Unique Needs of the Gender and Sexual Minority Community. And the way that the panels work for today is that we will start with a question, and it'll be a series of questions. We'll start with one panelist. You'll have about 2 minutes to answer the question, give or take. And then each person will be able to give their answers, and you have time for discussion if you'd like to discuss for a little bit, and then we'll go to the next question, and we'll start with a different person every time. Questions from the audience, we would love to hear from all of you. There are note cards set around the room along with pens. So if you have one on your desk, feel free to use it. There should also be some scattered around the room. And we have some at the beginning of the stairs and at the end of the stairs on either side if you don't have any. And for those of you who need continuing education credits, we have a sign-in sheet at the registration table. That'll be there all day. Just make sure to sign in and sign out. So to get started with our first panel, today we have Lauren Parish, Angela Carter, Del Rapier, and Carrie Hsia. Thank you. Would each of you like to introduce yourselves?
My name is Lauren Parish. I'm an acupuncturist and an OCOM grad, if there's any OCOM people in the room. And I work at Sacred Vessel and the Equi Institute in North Portland. We work out of the Q Center, and we serve the trans, queer, intersex, and non-binary communities. That's me.
I'm Angela Carter. I'm a naturopathic doctor. They, them pronouns, and I also work at Sacred Vessel and the Equi Institute out of Q Center, doing primary care and clinical direction.
I'm Del Rapier. I actually went to Pacific University, if anybody's from there. I work at Portland Mental Health and Wellness, where I do therapy primarily with trans, non-binary, and queer patients.
I'm Carrie Hsia, and first off, I'm going to say these two downplayed Sacred Vessel Equi Institute. Angie's the founder, and it's the first queer and trans clinic in Portland. And I did have space there when I first graduated for a little while. And I'm a chiropractor, did I say that? So I see a couple of the UWS students up here. Hi.
All right, great. If we're ready to get started, we'll go ahead and start with the first question. And Lauren, do you mind kicking us off?
Yeah.
Perfect. All right. What are some things you do in your practice to be inclusive and empowering to members of the sexual minority community with respect to communication and sensitivity that you wish everyone would do?
That's a good question. I mean, I think luckily in Portland, I think things are being more and more inclusive and becoming more and more comfortable spaces, although there's still a lot of issues that need to be addressed. And I think something that we all think of is like changing your intake forms, right? Like creating a space for people to write in their own gender, respecting people's pronouns and people's names. But I think something that we all need to do, like I think most folks, especially here, but most folks in medicine, like are coming from a good place, right? And I think we can't assume that that means that we're gonna do the right thing and make people comfortable, or that we're prepared to serve specific populations. So go to a training. I think that's the answer. I think if there's something that everyone could do, it would be to go to a training to really get the information and tools that you need in order to serve these specific populations. And we actually offer a training at our clinic. So just contact Sacred Vessel. It's a really awesome training led by Angie here. And please contact us, get involved. Yeah.
Okay, so from a primary care perspective, I mean, this is a talk that could go on for a couple of hours, and certainly I'll try to cover as many points as possible. But so for starters, yes, when you meet someone, you respect their pronouns, you respect their name. In EMRs, electronic medical records, we have, you know, most of the time we have two options. We have male, we have female. That does not cover the breadth of gender and sex in the least. There are, I mean, at the very least, there are many people who are intersex who don't have a spot in EMRs. And then there's folks who are transitioning, and, you know, there's more than just M to F and F to M. So the little drop-down check boxes, they don't offer enough. They don't, I think, really we need to advocate for EMRs putting in write-in spaces for people to put their actual identity, and then to auto-populate appropriately. Like all the auto-population in EMRs, it's so frustrating. It gives the sex that's attached to the EMR, and so it'll just say she throughout, and it doesn't work. So advocate for change within EMRs for sure. Learning about specific health issues within the communities is really essential. You know, looking at the differential cancer risks that folks who are gay men versus heterosexual men, and like with different sexually transmitted infections, and like screening for things that you wouldn't maybe screen everybody for, doing anal paps, like understanding that there's a lot more to sexuality than just checking a male or a female box, and that the rubrics that they give you, the rubrics of, well, if you're male, this is what you do. If you're female, this is what you do. They don't necessarily fit for people within the transgender community who have differential body parts, who have had surgeries, who have not had surgeries, who are on hormones. There's just so much to learn. There's so much information, and you gotta do your research. So definitely research EMR, and I'll leave it off there because I know we only have 2 minutes, and pass it on.
I would definitely second what Angie said about our what we call them electronic health records where I'm at. But one of the things you can do is oftentimes there'll be some write-in sections that may not be specific to pronouns or, you know, name or whatever. So you can sometimes just be creative in them. And what I do as a practice is every patient that I get, I put their pronouns, whether they're trans or not, so that it's not a unique thing for trans or non-binary folks. The other thing I've really learned to do in a therapy session is when they talk about a partner is ask what their pronouns are too, because that's showing that you're respecting their whole personhood, as well as the people who are important in their life. And it can be as simple as starting, "Hi, my name is Dell. I use they, them pronouns. How about you?" It's as simple as asking somebody's name. And so I would encourage folks to start to make it a simple practice rather than this big deal that you have to do.
In my EHR, like they were all saying, there's always a section that pops up when you click on the patient's name. There's always a part that kind of says, I'm a chiropractor, so most of mine would be low back pain. That's where I put the pronouns. So I also do it for every patient. That way it's just across the board. It's uniformed and it's right there in front of you. And specifically on the chiropractic end, and what I do teach my students is when you're treating a patient, don't look at gender, look at the body as a whole, biomechanics, referral patterns. So anytime there's hormone sensitive issues that come up like cancer, breast cancer, educate yourself on referral patterns and where they're going. So that way the whole gender thing actually doesn't come into play. So don't get stuck on that one thing.
Great. All right, if you're ready for our next question, then Angela, would you like to start off our next question?
Sure.
All right. Are there any unique health concerns that might be specifically addressed in this population?
So we're speaking specifically, just to make sure that I am clear, on the trans and non-binary and genderqueer community, or the entirety of the LGBTQI Two-Spirit community, just to clarify.
That is a great question. My understanding of this panel is more of an entirety, anything that would fall under gender and sexual minority. So it's very open-ended.
Okay. Well, that's a big question. Yes, there are a lot of unique health needs in this community for a variety of reasons. I would say that the top reason that I see morbidity and mortality in my practice is discrimination. You know, people facing discrimination. They face discrimination in the workplace because of gender and sexuality, in finding housing and getting access to resources, in having a community, faith-based community, friend community, family community. People get cut off a lot from community. This creates a high level of chronic stress. Chronic stress leads to patterns of disease. So, you know, we can talk about other aspects too, but really that is, I think, one of the biggest, most core pieces of any minority community that is oppressed, is looking at, like, they're higher risk for cancer, they're higher risk for diabetes, they're higher risk for activities that will put them at higher risk for contracting disease. It's about marginalization, it's about distress. And so in the core work that we do, we have to address that piece. We have to work to eliminate it from the culture so that people can be well and can thrive. I mean, there's so many other different pieces that I could talk about that are branches of that, but I think that is, from my perspective, the most important piece to remember is minority stress has a huge impact on health.
Left, please.
I'll continue on that from more of a psychology perspective. The thing that shows up a lot with my patients is, even if someone has some aspects of privilege, like let's say that they're a white identified trans person or a white identified queer person, their level of stress is going to be very different than my folks of color who have multiple aspects where they're going to be dealing with minority stress. And I will also say that even if someone has relative privilege in terms of not having directly encountered any sort of bias or discrimination, they live in a world that is constantly deluding them and you know, all you have to do is look at the television. All you have to look at is social media, and there are messages every single day that are simply microaggressions that after a while they add up. And the thing about, from a psychological perspective, is if you don't talk about that stuff, if you don't let that out, it resides in your body. And if it just lives in your body, ends up going to these folks, because you'll have physical symptoms, and that can go a whole range of ways that is totally outside of my scope of practice. But I see tons of anxiety, I see tons of depression, I see tons of trauma, sometimes from a perspective of, but my life is good, nobody's harassing me, why do I feel this way? It doesn't matter. If you're constantly hearing these messages, it's going to have a collective effect on these patients.
So pain, you mentioned that with microaggression. Most people here are in the healthcare industry, correct? There are certain diseases, there's certain diagnoses that are still kind of up in argument with whether it is biomechanically that's true or not true, or is it a psychological thing. So I like everybody actually just think about a time where you experienced hate or you felt like you were displaced somewhere. Somebody staring at you, some sort of microaggression, right? For example, for me, I get patients asking me all the time, where am I from? I'm from Seattle, Washington. And then they actually ask, where are you really from? Where are you from? So think about something like that. And what I find in the queer and trans community is that is constant. That is practically 100% of our lives. Walking into the bathroom, walking into a public place, walking into a community center. People already have like these judgy eyes, so the microaggression builds up. It leads to pain, it leads to body pain, it leads to emotional pain, it leads to so many, this big spectrum of problems that our bodies can have. So provide a safe space in your treatment rooms. I think that's the next question. I was going to jump into something else. So, but providing a safe space as soon as they walk into your clinic, kind of something that's more inviting, something where they feel more at home, more at ease. So it's not kind of like an attack on them or anything, or dull, I should say. A lot of clinics are kind of like that. But just think about everything as a whole, that everything's kind of connected.
Yes, everything that you guys said. Like, yes. I think unique health concerns that I work with a lot of trans patients specifically, and I think those are, I think those specific health concerns are like unique in a whole different way. So I'm going to just speak directly to those. Houselessness, absolutely. Poverty, absolutely. And everything that goes along with that, right? Like we're talking about pain that comes from constant trauma. From a Chinese medicine perspective, a ton of liver patterns, like, oh my God. And then of course this like, the thing I didn't think I would be treating as much as I do is like this special brand of eating disorder or disordered eating that comes with the body dysmorphia that is like specific to the trans community and non-binary community. Oh, something kind of cool, but like sucky for people, EDS, Ehlers-Danlos syndrome. We see so much of that in our clinic. Research needs to be done. Like a wild number of people with connective tissue disorders. Yeah, I would say those are the main things that we treat that I treat, that people come to acupuncture for. Yeah, addiction.
All right, great. We'll move on to the next question. And don't forget about your note cards. Someone will be coming around to pick up some of your questions shortly, I think, and we'll be able to mix those in with the questions that we already have prepared for our panel as well. So, Del, would you like to start with our next question? We'll keep going around in the same pattern. What are some common and harmful assumptions that practitioners make about gender and sexual minority individuals?
I think one of the big ones is that gender and sexual minority individuals are all the same. There's one path. There's one way to be. I'm going to speak mostly to trans folks too, because that's the majority of my work. But there's many different ways to be trans or non-binary as there is to be anything else. And so I think the most important thing to remember when you have somebody sitting in front of you is, regardless of their identities, you also have an individual in front of you. And so it's important to ask, what is that individual's journey? What is that individual wanting, needing? What kind of support do they need? When somebody comes in and says they're trans, I don't immediately assume that they want to have hormones. I don't immediately assume that they want to have surgery. I ask, okay, great, what does that mean to you? Again, I think a lot of times what happens with a lot of trans folks is that providers, being well-intentioned, exceptionalize their experiences as if they're so outside of the norm, when actually it doesn't have to be exceptional. It can be simply sitting with an individual and asking them, okay, tell me about your journey. What is it that you're needing? So.
Not assuming. I like that you say that, not assuming. I think a lot of people, when somebody walks in, they either have long hair or short hair, they assume a certain pronoun. A quick way to fix that is just use they, them. Practice using they, them. Don't assume that because they're a certain gender and they're within the community that they're automatically attracted to the other gender, that their partner is a certain gender, that they prefer one thing over another. Just the assumption. Those things just kind of have to be all out of your head. Speak with them, get information that you want, be nice, genuine about it. But I think that's kind of a big thing, is people just assume when they walk in. I know when I walk into a clinic and I meet a new doctor, I get a feeling. I usually get a feeling where they just assume that I'm lesbian because of the way I look, and their tone just changes a little bit. So just stuff like that to avoid.
I think Del, right? I think what I'm going to say is a little bit along what Del is saying, which is like not assuming that someone will want hormone type treatment or surgeries just because they say that they're trans. And I think when I talk to acupuncturists at large, they're always like, oh, I offer scar treatment therapies at my clinic. But that's like a moment in a person's life, right? If somebody does decide to have some kind of surgical, some kind of surgery, like that's a moment in someone's life. It's such a tiny percentage of people who've ever asked me to work with scars. And I also remember in school people being like, oh, I don't know about trans patients, yin and yang are just so imbalanced. What will we do? How do you understand the pulse? And that's like obviously BS. We're treating people where they're at. Everyone is out of balance, and in large and small ways. And we're just, working as well as we can to bring people back into balance. And I mean, we just went through all the things that we see the most in our clinic, and none of those things, very few of those things from an acupuncture perspective are going to be around, balancing hormones or working with people post-surgery. So yeah.
We were talking about where people make assumptions. Yes, that was the question. Okay, so it's I work with a lot of doctors training and a lot of students, and where I see folks having a lot of issues are in equating gender and sex with each other, that they are connected, sort of echoing sentiments that gender is not connected to sexuality, and sexuality sometimes can shift as people may go through transition. They may discover more things about themselves. I think don't assume that anything is static. Things can constantly be in flux and changing as people learn new things about the world and about themselves. And don't assume anything about people's sexuality. Just because someone identifies as a gay man doesn't immediately make that person a person who has sex. That person may not have sex with anyone. They may be a gay person. They may identify as a person who has love for a person of their same gender, but that doesn't mean anything about what they do. So taking that, disconnecting that, and really just personalizing medicine as much as possible. What do you do? How do you do it? What body parts do you use? I ask, where do you want to be swabbed? What body parts have come in contact with other people? That's where we'll go. We don't have to get into detail about what you do specifically, but, that's I think probably everybody else wrapped it up as well as possible. Other than that, just don't make assumptions, period. Don't make assumptions.
Great answers. Thank you. We're going to go ahead and throw in an audience question, if you're all okay with this. The question is, what correlations between EDS and gender non-binary expression are you experiencing clinically? And Carrie, would you like to start down here? I'll give you a chance to go first. Carrie.
Go for it.
I think most of us learn that EDS is it's rare. It's a musculoskeletal disease for people who don't know it. I went into ASHA as soon as I graduated. There were at least 5 EDS patients that came in. And in my mind, I'm thinking, all the teachers who taught me, I'm like, this isn't rare. This is like a normal thing that's just coming in, just walking in the door. But I was also at a clinic where I would say 75% is queer or trans. So it was a lot of people who came in were part of the community. So I don't remember specifically if my EDS patients were all trans or not. But I definitely think there's a correlation between the two. And that's one of the things that they were saying. There should be research done. And I actually remember probably about 2 years ago, Angie asked me to do research, 2-3 years ago. Maybe I was still a student. I don't like research at all. That's what I say, because I hate writing. But definitely more research needs to be done on that. So if anybody wants to do research on it, you can collaborate with Angie. But I'll let them add more to it.
The relationship I see is just that there's a lot. And Angie actually pointed this to me, and I get most of my referrals from Angie and other doctors at our clinic. But also along with that are other connective tissue disorders. So we see POTS a lot. We see, well, I will just pass it to you. Okay. You're the nerd on this. You should do the research.
Okay, so I have a clinic with around 900 transgender, non-binary patients who I see for primary care. I'm not seeing all of those people. I could not do that, but I have a number of doctors who work with me who also see those patients for primary care. And I began noticing maybe 5 years ago that there were more folks with connective tissue disorders in my practice than should have been expected. And I was just sort of perplexed. I kept seeing them come in. Either they had already been diagnosed, or they came to me with chronic pain, and we did the diagnosis, and I've had it confirmed by other people, and it's just, for some reason, very common. We have had families come with family members all being genderqueer and all having some kind of connective tissue experience. So it's still, we are one little clinic. We are seeing a preponderant number of folks. There's a lot of research to be done. I do not have a good answer as to why there is a connection, but it's something that I see. So if you have an interest specifically in this, come talk to me. I would love to get, I intend to get a case paper published at least at some point, and I'm hoping that other folks in other centers will echo back and give me some more information on what they see.
No? All right. That's okay.
Outside of my scope of practice.
You, of course, have the option to not answer a question. So we'll just dive right into our next one. And let's see, I think we're back to Lauren as our starting. Is that all right? Great. How have you seen treatment of this community change in the last 10 years? How would you like to see treatment of this community change in the next 10 years?
Yeah, that's a good question. Well, I mean, I think the big change happened, was it 2013 or 2014? That OHP, or that...
It was 2014 when pubertal suppression was first started being covered. So that's for youth. I'm going to turn my head because it's hard to talk with my head turned to the side. In 2014, OHP began coverage of pubertal suppression in youth who are transgender, who wanted to at least temporarily pause puberty so that they could either make a decision as to what hormones they wanted to grow up with, or permanently pause puberty so that they could transition appropriately into a body that felt more fitting for them. That was 2014. 2015 is when insurance coverage for all trans Oregonians by Oregon Health Plan began. And then I'll let you finish.
And Angie's not going to say it, but they were a really big part of pushing for this change, so it's awesome. I know me and my partner actually moved here for this reason, oh yeah, so with acupuncture, it's such an interesting time to be treating the trans community because it's a community that is to an out of control degree in poverty. Like the low income clinics, the community clinics that had been the place that served the poorer people who were able to afford that for acupuncture, we weren't really seeing. I was going to a community clinic before this change, and then even working at one until a year ago, and you don't see that many trans patients because sliding scale from 20 to 40 or whatever it looks like at that clinic is too much to pay, right? But now we're actually seeing OHP covering acupuncture, and they're cutting down on it right now. But it's this special point in history where my whole job can be working with the trans community. And I do see other patients, but it's this super magical moment, and I'm really hoping that it lasts. And I think it's going to be about a lot of activism in healthcare because I don't think that this is a community that will have access to acupuncture or anything that's seen as adjunctive care, or something you get if you have extra money in your pocket. And we're all talking about how much pain is part of what we see in our practices, and we're also seeing this crackdown on opiate use, but less and less money is going to acupuncture, is going to chiropractic work, is going to physical therapy. Just this year, OHP cut down the number of visits that people can get and combined them all. So now our patients have to choose between physical therapy, acupuncture, chiropractic, and massage therapy. And that's just not okay, right? So we all need to be doing this activism and expecting more for our patients, especially if we're going to act like we want them to get off opiates, right, and have other options. But anyways, that kind of took a little bit of a turn. The point is, right now is a really cool time. A lot has changed. I'm really hoping that we keep having more access to alternative medicine over the next 10 years. That's definitely a hope of mine, but I don't know. Yeah.
So I started medical school in 2007, and at that point, I had been volunteering with Outside In and sort of knew what was going on generally within the community. And I ended up mostly working at the community health clinics for my intern years. I did a lot of work at Outside In. I worked at Mercy and Wisdom, a number of other community health clinics. And that is where a lot of folks were getting their care, because insurance was not covering transitional related care at that time, because, again, because of pervasive discrimination, poverty. And so a lot of folks, there were a few providers in town, like Suzanne Scopes has been providing care. She's a naturopath. She's been providing care for about 30 years to the trans and non-binary community. And then Outside In had a group of volunteer doctors who worked there maybe twice a month to do a trans clinic. But there wasn't insurance coverage at that time, so there were very few folks even offering. There were a few doctors in town in the community who were serving community. But there really was a very, very small number of doctors doing the work, and there was very little information in the specialties. So if maybe you have a good primary care doctor, but going to a neurologist or going to see a gastroenterologist, or having to get going to see a gynecologist, like just horror. People had a really hard time finding good care where people understood who they were, their needs, their health needs, their community. 2012, the Insurance Board of Oregon made a requirement that all private insurance start covering trans-related care, and that definitely was helpful for a lot of folks, but for most folks who are on Medicaid, that didn't offer much in the way of anything. And so the trans clinic at OHSU continued, and these small practices continued until 2015, when transition-related care became a covered option, and then care began to sort of blossom in the city. In 2016, OHSU started the transgender health program and hired Amy Penkin, fluffy thing, and sorry, distractible. And then Legacy brought on Nola and Chris, and they have a trans health program now. So as coverage has expanded, as surgery access has expanded, some of the hospitals in the area have been stepping into offering more options for trans care and trying to diversify the care that is available in those hospitals. We still have a long way to go. We're doing the work, but people are responsive. The hospitals are listening. They're listening to the community. OHSU is forming a community advisory board right now to guide their transgender health program. So a lot of great steps have been made. My hopes for the future are, better and more coverage of electrolysis, facial feminization surgery, because that currently is not covered under OHP, and there are a lot of folks who really could use access to that. And just more engagement with the schools and integrating trans care into the curriculum as part of a core concept of the training, not just an elective. And yeah, more collaboration. I'll leave off there.
A lot of the work that I do around this issue is I do gender affirming surgery assessments. And so the way that I have tried to facilitate them is make them as easy and accessible as possible. They come in for one visit. We do an assessment. It's a biopsychosocial assessment. And then the next visit, they review their letter. And I think that, most of my patients that I work with are on health share, so they're not paying anything for that visit. You have to think about the fact that there is more access, but health share requires 2 letters. So that's 2 appointments at least with 2 different providers. which, you know, even getting access to go to an appointment can be a barrier. And finding a therapist who feels competent to do that can be, it's a ridiculous challenge. It really shouldn't be. I don't understand quite why some of my colleagues find that so challenging. But one of the things I would really like to see is that the insurance company, especially HealthShare, to catch up with the WPATH standards of care, because they are using really antiquated requirements in some cases that most folks who are informed are going by a more of an informed consent model. So I would like to see that continue to move forward with the insurance companies.
Unfortunately, with OHP, chiropractic is not, it doesn't cover chiropractic that well. I believe you get 3 visits, and it has to be either neck or back pain. So there's a little finagling around there. But what's changed is we're sitting here having this conversation. We're sitting here having this panel because people want to learn already. People want to be inclusive in their clinics. And I think people are just talking about it more. I have more people coming up to me asking about, you were talking about pre-surgery. I do pre and post-op rehab, people who bind, helping people regain their movement, because binding kind of restricts a lot of things. So more people are coming up and asking me. I have people who email me asking what they can do. And since I only get a couple visits with them, I try to educate them as much as I can with things that they can just kind of take home and do. And I do urge them to pass it on to other people so that we can help spread the word as much as possible, since in my field, OHP, I can't recruit very much of those people coming in.
All right, we have a question from the audience. So Angela, would you like to start? And this is from a 3rd-year ND student, just for context. And the question is if you have any recommendations on starting a practice in an area where trans medicine is limited and awareness is limited. For example, how to reach this population and where to find them.
Well, so if you're going somewhere rural, there are definitely still trans people there. And if you're going somewhere urban, then you're more likely to find things like queer community centers. So that's a great place to start. If you want to find folks to come to your practice so that you can help them, you can definitely post in queer resource centers. You can get involved in those resource centers, offer information, classes, like do some research, gather some information, bring that knowledge, and share it with the community specific to the health needs of that community. You know, support groups, even in rural areas, there are bound to be support groups in one place or another. Sometimes you have to travel 2 or 3 counties to find them, but they're still out there, and people do come from all over the place to those support and resource groups. So, you know, if you can get a hold of the facilitator and ask in what way you can be of service to the community in that area, how you can support. Main thing is, you know, don't come in and start something that somebody else has already done. Help them do that work as much as possible. Get involved with the community that's already there. Yeah, just be a resource. Be a resource to the community. Have the knowledge and share it. And when people learn that you have knowledge and that you have the ability to offer a respectful practice, they will come to you.
One of the things I would say too is, especially if you're going into a community that you're not really familiar with, it can be really important to first ask questions. Ask what are the needs of this community, because it's sometimes easy to go into community thinking, I know what this community needs, and you can be totally wrong. So I would say, you know, go in and do some information gathering first and find out you said, if someone's already doing the work, can you support that? Or if there's some missing needs there, what those are and how you can best meet those needs.
All right, we'll move on to our last question that we had planned for today, which is providers will make mistakes when working with individuals from these populations, for example, misgendering clients. What is the best way for a practitioner to recover from these mistakes and to reestablish or maintain rapport with our clients?
I would say the best thing to do is acknowledge you did it and then move on. I think one of the biggest discomforts that happens, I'll just speak from personal experience, is when somebody misgenders me and then makes it about them. I'm so sorry, I didn't mean to do that, oh my God, blah, 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 blah. It's like, okay, now this is totally about you and you misgendered me. So I think the best thing, again, is just, sorry, correct the pronoun, correct the name, correct whatever you said incorrectly, and then move on.
Don't over apologize, I'd say too, because like you said, it does change the focus on somebody. I think the most important thing is be sincere about it. Apologize, be sincere about it, and actually learn from them. Say, you can even just apologize and say, I'm sorry, this is new to me, but I will respect your pronoun. Whatever, he, she, they, them. But don't over apologize. That tends to make it awkward.
A lot of the same. As an ally to the trans community, I would, the feedback that I've gotten back the most is pretty much exactly what Del said, like just apologize and move on. And then I think something that we can be doing and letting our parents and our grandparents and like coworkers know that they should be doing is practicing correct pronoun use when those people are not in the room with you, right? I think that's a mistake that a lot of people make, is to think like, I don't know, I think it's some weird embarrassment that people have or something, where like when that person's around, they don't use the correct pronouns anymore. It's really silly, and it makes you misgender people when they're in front of you, and it's just effed up, right? So yeah, apologize, move on. And remember that they're there for healthcare. They're not there to help you process, and become a better ally, right?
Echoing all of that, and the one other piece I would add is maybe advocating for your patients if they have someone else in the room who is a parent or a friend or in some way connected to them, and they use the wrong name and they use the wrong pronoun, or if you're working with another provider who is using the wrong name or the wrong pronoun, even if there is a power imbalance there, if you are the student and they are the teacher, or they're the chief resident and you just started, say something, correct them. It may piss them off, but it's the right thing to do. And if they continually do it, it's as a protective person, as a protective provider for your patient, it's your responsibility to create that safe space for them, and that's a very important piece of it, so that they can feel that you respect them for who they are, for what they are in the room, and that they know that you'll keep them safe.
I just wanted to add, don't avoid using pronouns. Like, that is just like starkly obvious to people, and I think frequently makes people sometimes even more uncomfortable. Like, don't avoid using pronouns.
Great, and I think that we have time for one more question while we've got you all in a room. You're okay with that? And it's another audience question: how to be an inclusive PCP for trans people so we don't have to see different doctors for gender dysphoria, pain, disorders, etc. And whoever would like to start on this one.
I'm the PCP, so I guess I should talk. How to be inclusive in all of those areas so that people don't have to see a number of different. I specialize in hormone therapy, but that certainly doesn't mean that I don't do all different other kinds of primary care too. I think that, like, any other health condition that's being managed, this is not a disease. This is a situation where a doctor's supervision is required. Simple as that. So in any case where someone is being managed by a doctor who is in primary care, they should have access to whatever it may be. So if they need insulin because they have diabetes, they should be able to get that from primary care. If they have pain, they should be able to get pain management from primary care, unless it's super complex. So, it's no different really than any other situation. This is just another supervised situation that we manage, that we should manage, that everyone should manage, that everyone should know how to do. It's not complicated, really. There's nuance in certain ways. Certainly, there are times and places where a referral would be warranted, but just basic hormone therapy is more simple than, I would say, insulin for diabetes by far. You just, follow the protocols, basic labs, and you can totally do it. It's not tough. And being able to access all of that in one place and not having, I have to go to 4 different doctors to get all my health needs met. And that's absurd. I shouldn't have to go to 4 different doctors. And it's just because of discrimination, simply put. It is a simple thing. It should be in everybody's education, regardless of what kind of work you're doing. Because, there was a study done recently. 2% of American high schoolers identify as transgender. It's not a small number. So, you need to learn about everybody in the work we do. Anybody else want to put in? Yeah, do it.
One other thing, and this is probably going to feel contrary, because I know when you're working, slowing down feels like the last thing you're allowed to do. But please slow down. Think about how easy it is to take a few extra seconds to look a little bit deeper into somebody's chart and not look at maybe their legal name and look at the name they use, to look at the pronouns they use. Because I've seen a lot of experiences where somebody is visiting a doctor, which is already vulnerable. Maybe they're visiting a doctor because they're in pain, more vulnerable. And then somebody uses a name that they do not use, or a pronoun that they don't use. And then the next person does it. And the next person does it. Even though when they checked in, the person at the front desk said, oh, what name should we use? It's there. So if that's an inclusive practice too, everybody in a practice needs to be on the same page, so that person who's moving through from front desk to triage to seeing you as a provider feels like, oh, I'm seen here. Because anything else, it's like they don't see me. And think about things like taking vitals. Every time I go to a new doctor, my blood pressure is sky high because I don't know how they're going to treat me. But if I go to my regular naturopath, my blood pressure is perfect because she sees me. So that's something, it's simple. You do have to slow down, though, so you're just taking that extra step to make sure you're respecting who's in front of you.
I agree with the training. Train your staff. Practice with your staff using pronouns. I think also a great way, I'm not primary care, but I do have a list of referrals. I refer to Sacred Vessel all the time. That's kind of my go-to. I just got Dell's card, so now I know another referral. So go out, meet your community, know who they work with. See if you trust them. I don't trust every doctor out there, so I'm not going to refer to the people I don't trust. But I do have a list of, I would say, most practitioners that I refer my patients to.
I would echo, train your front desk. And we actually just hired new front desk people, so this is just in my brain right now. But your front desk should reflect the people that you serve, the people that you want to serve, right? So hire in a smart way. And we also had a whole conversation about like, what's more important, somebody who already knows all the systems and so you don't have to train them on that, or somebody who's like socially competent and has like a social justice lens, or, you know, that's so much harder to train, right? So like hire people with the right priorities. And I think, I mean, we all know anybody with a front desk staff knows that they're like the most important part of your office. So, you know, find people who get it and treat them really well.
Great. I think that's a great answer to conclude our panel on, and I think that we're out of time for today for this particular panel. So I want to say thank you to the audience for being so respectful and for all of you being here. And thank you to everyone on this panel. Those were wonderful answers, and we really appreciate your time and your experience. So thank you.
Thank you all for being here and listening. It's really